Hi, I'm Dr. Sarah South, a medical director in the Genomic Microarray Laboratory at ARUP. Today I would like to discuss the interpretation of the genomic microarray technology in the postnatal constitutional population. Genomic microarray is used to detect losses and gains of DNA, also known as copy number variation. Genomic microarray is recommended by multiple professional societies as a first-tiered test for individuals presenting with intellectual disabilities, congenital anomalies, and autism spectrum disorders. Use of this technology has identified widespread copy number variation in both patient populations as well as the general population. This indicates that not all copy number variations will have a pathogenic clinical consequence. Therefore, when reporting the results of genomic microarray, it is important to include both the detected copy number variations and an evaluation of the likely clinical consequence in the interpretation. The American College of Medical Genetics, also known as the ACMG, has recently issued guidelines to assist in the evaluation of copy number variation detected in the postnatal constitutional setting. These guidelines are briefly outlined in this spotlight, and additional information may be found in the ACMG Standards and Guidelines publications available at www.acmg.net. A systematic evaluation of genomic microarray results initially involves familiarization with well-established genetic syndromes, with the recognition that continuing education and monitoring of the rapidly expanding medical literature is required. When evaluating the copy number variations of a specific case, many laboratories may employ a threshold on the size of the detected copy number variation, such as 50 kilobases for deletions. Although size thresholds may be useful in order to guarantee technical performance, there is not always a correlation between size and pathogenicity. Larger copy number variations may be more likely to have a pathogenic clinical consequence due to increased gene content, but it is also clear that small copy number changes may be pathogenic and large copy number changes may be benign. Therefore, a consideration of the genomic content within the deletion or duplication is the most relevant interpretive consideration. When considering the genomic content, the genes within the interval should be evaluated for their dosage sensitivity. Are they haploinsufficient, where loss of one copy is likely to have a clinical consequence, or triplosensitive, where gain of an additional copy may have a clinical consequence? When genes are identified as pathogenic in the medical literature, the nature of the disease-associated mutations should be carefully interrogated. For example, a dominant disorder may be due to haploinsufficiency, but may also be due to a specific gain-of-function mutation. The haploinsufficiency would be relevant for a deletion of this gene. However, the gain-of-function outcome is not likely relevant for a deletion of the same gene. In addition, duplications that involve only a part of a gene may or may not disrupt gene function. Deletion of a gene associated with a recessive condition may only suggest carrier status for the condition, and copy number alterations affecting only intronic sequence or gene deserts may have no effect on gene function. It is also useful to remember that predicted gene function based on model organisms or in vitro studies is only an inference until well characterized in the human population. Detected copy number variations should be compared to both internal and external databases. These databases should track copy number variations in both patient populations as well as the general population. It is also worthwhile to consider issues of incomplete penetrance, variable expressivity, age of onset, and potential imprinting when considering copy number variations identified in the general population. The frequency of these copy number variations should be considered, as well as the detection of these copy number variations in multiple independent studies. With these evaluation criteria in mind, there are three recommended categories of clinical significance: pathogenic, uncertain, and benign. A pathogenic copy number variation should be documented as clinically significant in multiple peer-reviewed publications. It is possible that a pathogenic copy number variation may show incomplete penetrance or variable expressivity, and therefore not all individuals carrying the copy number variation may be clinically affected. However, it is still recognized as a risk factor for pathogenic clinical consequence. The category of uncertain clinical significance represents a fairly broad category, and some copy number variations initially classified as uncertain may at a later stage be classified as pathogenic or benign. It may be helpful to subcategorize the uncertain clinical category into likely pathogenic, likely benign, or uncertain without further subclassification. This may allow for more information concerning the genes within the copy number variation to be explained within the report, and yet still convey that additional information concerning either the gene function or the frequency of the deletion or duplication within patient and control populations is required for clinical significance to be more firmly established. Benign CNVs may or may not be listed in the report, depending upon the laboratory's specific policies. There are special considerations regarding the reporting of unanticipated clinically significant findings that may not be related to the reason for testing. These have been commonly referred to as incidental findings. They may include identification of carrier status for a recessive condition, the detection of an adult onset or pre-symptomatic condition, or detection of a copy number variation associated with a risk of neoplasia. Laboratories should have clear guidelines concerning the reporting of these findings. Recessive disorders that have clinical features that are consistent with the reason for referral may be useful to report, as the copy number variation may be one hit and there may be an as yet unidentified sequence level mutation as the second hit. In these cases, recommendations for further molecular testing may be considered. However, it is important that the report clearly states the recessive nature of the detected condition and that the CNV detected is not diagnostic without the detection of a second mutation. For the identification of a clear adult onset or pre-symptomatic condition, it is a general recommendation that these are reported to facilitate early access to medical care. For copy number variations associated with the risk of neoplasia, those with a clear pathogenic nature and with clear information concerning risk, tumor spectrum, and clinical management should be reported. Speculation regarding putative tumor suppressor genes or oncogenes should be avoided. With issues of incomplete penetrance and variable expressivity, it is important to remember that the determination of a copy number variation as inherited or de novo may not significantly assist in the classification of the copy number variation as pathogenic or benign. It is only through ascertainment of the frequency of that copy number variation in large patient populations compared to the general population that pathogenicity or benign nature of copy number is well established. In the absence of large data series for a particular copy number variation, there should be a cautious inference based on inheritance alone. In conclusion, the interpretation of the clinical relevance of a detected copy number variation is complex. There is no single formula or algorithm that can substitute for a thorough evaluation, competent training, and sound clinical judgment. Thank you.